Now I invite Dr. Swetha K. She is working as glaucoma consultant in Jyoti's Eye Care, Kannur. She'll be explaining central clues, macular involvement, and functional footprints in glaucoma. Over to you, Dr. Swetha.
Thank you, Dr. Manju. Warm good morning. I'll be talking more on the central clues, macular involvement and its functional footprint in glaucoma. Generally, when we talk about glaucoma, we tend to look at the disc and the RNFL. Now, I would like to you all to shift your focus a little bit to the macula. So, why look at macula in glaucoma? We know that macula is important for it because once it is affected, it can affect the quality of vision, the reading speed, the contrast sensitivity, and almost all the daily function. So just an anatomy refresher, we know that when the light falls on the fovea, it goes through the RPE, the bipolar cells, the ganglion cells, and this comes out as the retinal nerve fiber layer into the optic nerve head. So 30 to 50% of all the retinal ganglion cells, it is present in the macula. And this parafoveal retinal ganglion cells are really thick and it is easily affected by pressure changes and can get affected in glaucoma. So this is the area where we are going to focus on. So central damage do occur earlier than we think. It is not that traditionally what we saw, the peripheral, glaucoma is a peripheral disease. No, macula can also get affected. So these are the fibers, especially the macular fibers can get affected in myopia, normal tension glaucoma and some of the early glaucomas. So coming to the structural clues, I'll be focusing on both the OCT and visual fields. The OCT which I'm going to show is a spectralis OCT. And here the spectralis OCT, it can show all the 10 layers of glaucoma, all the 10 layers of retina separately. And what we are interested is a ganglion cell layer, which will be shown separately. And we know that the optic nerve fibers are arranged, how it is arranged in fundus. And when we take a visual field, this is the octopus visual field. Octopus visual field, we have the G program. And these points are arranged in the same pattern as this retinal nerve fiber layer. So we have this 10 degree, if you see inside the 10 degree, you have so many points here. The central 5 points are there exactly at the macula and surrounding that we have these many points. So when we take the G program, it can focus more on the macula. Also macular test patterns, if you see the M pattern, 45 central points, we have dense points and 36 points are there surrounded. Or we even have the 10-2 program, which is but equally spaced. In Humphrey's field, we have the 24-2C program, which already Dr. Manju has shown. You have 10 extra points in the center in 24-2C program. So now I would like to show what the normal ganglion cell layer looks like in a normal people. You have a regular donut shape pattern. This is a normal GCL. So when you have early glaucoma, the early red flag signs, what you have to see is this breakage of this donut pattern. The small break which you see here, that is the first sign that something is going on. And even the hemisphere asymmetry which is given in the retinal layers, you can see that superiorly there is some asymmetry from the inferior area. So this is a patient who was diagnosed with a normal tension glaucoma. You can see that superior rim is also thinned out. The RNFL is slightly thinning and the ganglion cell layer I have already shown. So this patient, when I saw the octopus field, you can see that the central 10 degree is where it is affected. It's not in the periphery, it's mainly the central 10 degree. You can see the inferior. This will be clearly shown in the cluster analysis. If you take the cluster analysis, you can see that little darker shade, 6.2, that is where. So you can see this here, superior RNFL is, there is a small RNFL thinning there. Now coming to the moderate glaucoma, this is some typical, whenever you're seeing the established glaucoma cases, the ganglion cell layer will look like this. That will be a snail shell pattern, what you see, and you can see the hemisphere and asymmetry. Inferiorly, that will be, it will be shown. And the deviation map, if you see, ganglion cell deviation is the first which you see, and the second is the RNFL deviation. So visual fields, when you take, it will have a superior arcuate scotoma. You can see that it is definitely involving the central 10 degree. Now, I would also like to shift your focus on the advanced glaucoma. Generally, when we say advanced glaucoma, we say that we cannot use OCT. You get an RNFL floor defect, and even visual field changes when you see there will be a constricted field. It will be difficult for the patient to do the visual field. But if you see at the ganglion cell, both of these patients are 0.9 cupping, and RNFL is definitely having a floor effect. So if you see the first patient, the ganglion cell, you can see little bit of ganglion cells in the nasal. The 30, 36, 32, 34, that green yellow area is where we have to concentrate. If you have something like this, you can be sure that if you're going to operate this patient on, he's not going to lose his vision. He will retain the central vision for sure. This is something which I definitely use whenever I pose these patients for trabeculectomy. But the second patient, the ganglion cell is totally lost. Those patients, it is little risky. So not only that, you can use, so if you see the deviation map, it will be like this. And fields will be like this, but we know that elderly patients doing field is really difficult in such cases. And also look at the amount of GCL left. And this can be even used for progression. I say this progression, it may not be seen evidently in the other. If you see the values here, 46 and 50 there, and the second one 41 and 48, the spectralis actually has an anatomic positioning system which exactly takes the scan, the same area the next scan also. So this will be the exact area which is going to get scanned. So even these slight changes, we can be sure that something is going on. We need to alter the treatment. So this may not show the, so even here inferiorly if you see 43-35 and 41-33, this is a very subtle change. I do not say that this is a very significant change which you are going to get in as a progression change in a visual field or OCT, but definitely given time it is going to give that flat map, the downward slope in field. And you have something here which shows this red area which you see, the superior and inferior, the RNFL fibers, this shows the change. There is some thinning happening. So you can use all these things to monitor, to get a flat, this is an RNFL thickness progression analysis. To get something like this, there should be a significant change. But what I'm showing is something which is even before this. We need to always detect it a little more earlier. Also, you can use a asymmetric map between right and left. So what I would like to stress is have a systematic approach. You have to see the rim, you have to see the RNFL as well as a GCL. You get a GCL change, no RNFL change, that is not going to be glaucoma. You see an RNFL change, no GCL change, that is also not glaucoma. All three together has to be there. And also this can also be used for detecting whether it is definitely glaucoma or not. In this particular example, you can see that temporal RNFL fibers are thinned out, and GCL pattern you see like this. It is actually generalized thinning of GCL. If you take the deviation map, you can see that papillomacular bundle is affected and the GCL is also affected. This is not glaucoma, it is something other than glaucoma. You have to evaluate for that. But if you have ERM and some macular conditions, you definitely can't go and check for the macular. So finally, I would like to say that don't stop at the disc, don't stop at the RNFL. Look forward and see the glaucoma, GCL also. Especially this is important when you have a myopic cases where you can't get a proper RNFL, you don't get an idea. You go look ahead at the GCL, it definitely gives you an idea whether this is glaucoma or not. Thank you.
Thank you, Dr. Swetha, for that